Hey everybody, my name is Jhun and this is Mabee.
Hi there.
And we are here to answer some of your questions from the Hippo Mailbag. Today we actually have a question from Hippo EM Board review, so let's get to it.
All right, so this is a question from Daniel. If a patient is critically ill due to severe polycythemia and requires immediate life-saving interventions, what would those be?
That's a great question. So we should take a step back and take a look at the picture of polycythemia. So it comes in different flavors. There's primary polycythemia, which is what I'm assuming is, in this case, is what you're asking, Daniel, but otherwise that's polycythemia vera. That's a bone marrow neoplasm, myeloproliferative neoplasm, where you just generate too many RBCs in the bone marrow. There's also secondary polycythemia, where it is high altitudes, or you have inappropriate levels of EPO or erythropoietin levels being secreted by like a renal carcinoma, or if you have COPD. So let's take a step back and say, well, polycythemia vera, if that's what we're assuming, there's a couple of things to know about it. And that's, again, when the bone marrow generates too many RBCs. The diagnostic criteria, really for the test purposes, you just need to be remembering it when you see a hemoglobin level greater than 18.5 in men, hemoglobin level greater than 16.5 in women. In truth, though, there's a lot of other things they have to do: genetic markers, serum EPO levels, all that stuff. But classically, in the question context, you'll also see presentations of constitutional symptoms. Fatigue is a very classic finding, as well as pruritus in more than half patients. And there's this really interesting finding called aquagenic pruritus. Yeah, where you go, your pruritus is triggered by, like, let's say you go take a warm bath. Really strange, but that's quite unique to polycythemia vera. So that unfortunately there's no cure, but if you do diagnose it and monitor it, the mean survival is almost no different than regular people. But classically, it's in the older people who gets diagnosed, 60s, 70s.
So in that process, then you're thinking about like this hematocrit and this hemoglobin level at these, just like outstanding amounts, right? So what do you do with that kind of like viscosity of the blood? How do you address that?
Yeah, so just like you were talking about, there's sludging. It's almost like honey running through your veins and arteries. And so it can lead to a lot of thrombotic complications. It can be on minor levels, like microvascular thrombosis, where you have this other unique finding in polycythemia vera called erythromelalgia.
Did you just make that up?
Yeah, that's right. It's a word that I made up. No, it's really microvascular thrombotic complications in your extremities. And so you just have swelling and plethora, really redness, and it's very, very painful. There's a specific treatment for that involving aspirin and hydroxyurea and other things. But on the bigger level, more life-threatening are the major vascular thrombotic complications. You're talking like stroke, PE, MI. And those are the ones that you really have to be concerned about.
So what do you do? What's the evidence to direct you towards treatment?
Great question. And so it's good old-fashioned bloodletting, phlebotomy, really. So if you have severe polycythemia vera with a major vascular thrombotic complications like MI, stroke, PE, that's when you actually just do some phlebotomy, just good old phlebotomy. Believe it or not. It's not a medieval torture technique anymore where you release the humors. This is actually what you do. The real deal. Yeah. And unfortunately, there's no good evidence. There's no consensus guideline kind of thing that's published. Really, it's from expert opinion from various sources, where some people suggest you just empirically remove 500 cc's of whole blood. You just let it drain out, half a liter. They will recommend replacing that volume if you can with isotonic fluids, just to prevent postural hypotension. But otherwise, some other sources will say try to phlebotomize till you reach a target of hematocrit less than 55%. Again, a little arbitrary still, but there's no good evidence that's what the targets are.
So after you suck out all this blood, how about like the thrombotic complications?
Oh, right. So, well, while you took care of the polycythemia part and the sludging, the actual sequelae of the actual major thrombotic complications like the stroke, MI, PEs, they're unchanged. The treatment's unchanged. It's per the current guidelines for those individual things. So that's pretty much it.
Good to know.
Thanks for the question, Daniel. And until next time, check in for more questions that we'll answer through the Hippo Mailbag. Thanks.
All right.